I wanted to thank you and the rest of the organization for inviting me to talk about pulmonary hypertension associated with left heart disease as part of the update on the seventh World Symposium that occurred in Barcelona over this prior June. My name is Brad Maron. I am the Senior Associate Dean for Precision Medicine at the University of Maryland School of Medicine, the Executive Co-Director for the University of Maryland Institute for Health Computing, and the Director of the Clinical Pulmonary Hypertension program there. And it's really an honor to have a chance to talk a little bit about what the task force on left heart disease and pulmonary hypertension focused on during the symposium, and provide that in a way that I hope the audience here finds to be clear and straightforward. These are the conflicts of interest related to pulmonary hypertension. And I think the way to break down what is otherwise a pretty wide and important and deep topic is according to the five main themes that we tried to address during the symposium, focusing on the definition of pulmonary hypertension, left heart disease, a new paradigm for staging PH-LHD, an approach that focuses on disaggregating different causes of group 2 PH, since we understand the importance of overlapping phenotypes to clinical care of patients, the importance of decentralizing clinical research to address questions that are pressing but are unlikely to be resolved using the current and conventional model, and then also focusing a little bit on clinical trials and novel strategies that we think will be ultimately important to integrate moving forward. So starting a little bit with the definition of PH left heart disease, we aligned closely with the task force that was in charge of the definition and clinical classification of PH more broadly, reinforcing our support of thresholds that use a mean pulmonary artery pressure of 20 millimeters of mercury to define elevated pulmonary pressure, leading to a diagnosis of PH. And in the setting of left heart disease, maintaining a pulmonary artery wedge pressure threshold of 15 millimeters of mercury. We agreed with the existing PH subclassification using a pulmonary vascular resistance threshold of 2 Wood units to delineate isolated post-capillary PH from patients that have combined pre and post-capillary PH. And there's a lot of discussion and narrative around the relevance of decreasing the PA pressure and pulmonary vascular resistance thresholds from 25 to 20 and 3 to 2 Wood units respectively. But I want to emphasize that in the context of these conversations, the goal is really to point clinicians towards earlier diagnosis and recognizing risk is associated with these hemodynamic thresholds in the context of all-cause and heart failure and mortality, as well as hospitalization. And we want to make sure that the interest in these revised hemodynamic definitions emphasizes early diagnosis and not necessarily immediate treatment with any disease-specific therapies. That should be reserved really for information that's from clinical trials rather than epidemiologic reports, which is what largely has inspired the current classification system for hemodynamics in PH. There is clearly a continuum of clinical risk by pulmonary artery wedge pressure. This figure shows the spectrum of adjusted hazard ratio for mortality and percentage of mortality in the national VA CART database, which couples together information from all of the cardiac catheterization laboratories around the US, allowing us to achieve a patient population size that enables statistical modeling for these hemodynamic variables across a wide spectrum. And what you can see here is that the importance of low pulmonary artery wedge pressure on the left side of the figure is associated with a high mortality in patients when PVR goes up. And then on the right side of the figure, there is a continuous positive relationship between increasing pulmonary artery wedge pressure that begins around 15 millimeters of mercury and continues all the way to the end of the measurement spectrum to a level of above 35. And within that range, you see that between about 12 and 15 millimeters of mercury for pulmonary artery wedge pressure, there is uncertain associations with wedge pressure and adverse outcome. And this raises the question of whether there's a spectrum within the wedge pressure continuum that really itself is insufficient to drive prognosis. And that spectrum leads to the possibility that maybe there's missed opportunity here to define wedge pressure across a more individualized definition in which a range between around 12 to 15, possibly up to 18, is more consistent with the resulting zone of uncertainty where individual patient context, that could include risk factors for left heart disease, it could include risk factors for pulmonary arterial hypertension or other syndromes that cause pulmonary vascular disease, really need to be prioritized so that we're using our physician and healthcare provider-based instincts to classify patients correctly, as opposed to being lulled into assuming or making a reflex decision that a specific number acquired from a right heart catheterization in and of itself is enough to provide the definitive classification. And you can see here on this slide that there are a number of factors related to the methodology of the right heart catheterization, which itself can cause subtle changes in the recorded measurements, which in turn, if we don't focus on contextualizing that to the individual patient, could and has been shown to result in misclassification, which in turn raises all sorts of questions about appropriate care, inappropriate medical therapy, and all sorts of other issues that we want to try to avoid when thinking about how the information we communicate affects clinicians at point of care. We recognize that for each one of the different themes, there are important gaps in evidence. We, as I mentioned, have emphasized that the wedge pressure measurement should be interpreted in the clinical context of left heart disease, especially in those patients with left heart disease. Risk factors are those that have established left heart disease. We propose a wedge pressure range of uncertainty that certainly is between 12 and 15, but it may extend all the way up to 18 and has to be considered within the context of the individual patient at hand. Moving on to the second major theme, we introduce a new paradigm for staging pulmonary hypertension and left heart disease. And this was born out of a number of comments and reports in the literature trying to deconstruct the binary approach to recognizing and diagnosing PH left heart disease as either being consistent with a specific hemodynamic criteria or not consistent. This is really a disease that, like all other diseases, falls on a continuum of clinical progress, and we want to make sure that we're orienting our approach to how that stage may be relevant in the decision making for a given patient. So we recognize that PH is a distinct and potentially modifiable entity within the wider heart failure syndrome. Our goal is to approximate pulmonary hypertension as it relates to left heart disease severity, so that we are considering these much more closely aligned, contextualize the data on PH for the purposes of left heart disease and PH treatment selection, as well as escalation, and really enable early disease recognition and referral to specialty heart failure or pulmonary hypertension centers prior to the onset of advanced disease. A lot of what we're trying to propagate in the symposium from this task force, as well as in reports in the literature, is earlier disease recognition, so that we are not, as a community, growing comfortable with engaging patients with end-stage heart failure at the first point of contact, which is by and large what we see in clinical trials that even focus on incident patients with pulmonary hypertension. To create this concept and to put this together in a visual, we aligned our model with the current American College of Cardiology, American Heart Association heart failure staging system, And ultimately, this, we hope, will inform a novel clinical trial design that targets patient subgroups. And in this model, as you can see here, we have 4 stages. Stage A is defined as at risk. We see evidence of structural heart disease in stage B, symptomatic heart disease in stage C, and then advanced or right heart predominant patterns in stage D. And across these 4 stages, we have different individual parameters, clinical characteristics, hemodynamic progression, potential therapeutic strategies, and then future investigations. Where stage A is defined by risk factors, the presence of comorbidities. There may be a subtle elevation in mean pulmonary artery pressure, but this is occurring in the absence of a decline in pump function. There could be a loss of left atrial compliance that may be evident on electrocardiography. And in these patients, we tend to recommend lifestyle modification and comorbidity management. That may mean that they are eligible for SGLT2 inhibitor or GLP-1 agonist treatment per standard of care guidelines for left heart disease, not necessarily for pulmonary hypertension treatment, since those therapies are not proven to mitigate or improve pulmonary vascular disease per se. When we move on to the clinical characteristics of stage B, we start to recognize hemodynamic congestion, evidence of left atrial hypertension, the development of mild to early moderate functional burden in the context of World Health Organization functional class staging 1 and 2. This remains an isolated post-capillary pulmonary hypertension predominant presentation with pulmonary venous congestion, a reduction in pulmonary artery compliance, and changes in hemodynamics that we expect in patients like this, where the pulmonary vascular resistance begins to rise in line with a mean pulmonary pressure that's rising disproportionately greater than the change in wedge pressure. And then the potential therapeutic strategies are outlined here. They mimic what we see in stage A, but we also want to consider earlier engagement in potential clinical trials, focusing on maintenance of sinus rhythm, ambulatory hemodynamic monitoring for patients that tend to experience multiple or recurrent hospitalizations. In patients with stage C, we recognize more commonly the presence of combined pre and post capillary pH predominant presentations, more advanced symptoms. There is probably evidence of pulmonary venous and arterial remodeling in the pulmonary vasculature, and that this really sort of marks an inflection point in the hemodynamic trajectory that's compatible more with moderate to severe elevations and changes in hemodynamic profile. And ultimately, in those who experience advanced or stage D right heart predominant presentations, we see evidence of end organ injury in the context of ascites. These tend to be diuretic resistant patients with New York Heart or World Health Organization functional class 4 symptoms. There is a clear pulmonary arteriopathy that influences unfavorably the right ventricular pulmonary arterial coupling pattern. And these are certainly patients that need to be considered for clinical trial enrollment, referral to expert centers, which could have occurred earlier in the staging process as well. And in individual cases, drugs that could mitigate the overall clinical profile can be considered, provided that risks and benefits are explained clearly, and that in the majority of these cases, evidence base is simply not there to support the use of pulmonary vasodilators as an option. Gaps in evidence related to this staging system is that clearly we need prospective and comprehensive phenotyping data to affirm or refine some of the details that I mentioned in each stage. We have to understand how to quantitate the prognosis that's implied at each different stage and the best approach to mitigate that risk. We also want to understand generalizability of data that define each PH left heart disease stage to patients across different demographic, geographic, and socioeconomic profiles, which at present is unknown. And that should be an important consideration for future studies. And then ultimately trying to gather prospective data looking directly at the effect of currently used and increasingly utilized left heart disease treatments such as SGLT2 inhibitors and GLP-1 agonists on the pulmonary hypertension profile of patients, as well as the opportunity to initiate earlier to potentially mitigate progression of PH-LHD is a very exciting area for us to think about moving forward. Okay, so shifting gears now to the third major theme, which is disaggregating group 2 PH, including overlapping phenotypes. And this is important now more so than ever, since we are increasingly recognizing that there are unique differences in the epidemiology, pathophysiology, and prevalence of PH within different subgroups, and that the therapeutic approach now varies substantially by underlying pathophysiology. So it's increasingly important not to contemplate this clinical problem as a monolithic disorder. We really need to take this critical opportunity to consider whether our patients that we see in clinic should be considered for disease-specific therapies that address underlying causes ultimately that lead or increase the probability of developing pulmonary hypertension. And we know that this is timely because the PH-LHD framework has largely been stable over the past 5 years, focusing on heart failure with preserved ejection fraction, heart failure with reduced ejection fraction, and then sort of more globally speaking, the concept of valve disease. But the profile and pathophysiology, prognosis, and treatment are not equivalent across these subtypes. And in fact, we can take a much more contemporary view of this, thinking a little bit about opportunities to engage patients for initiation of disease-specific treatments, particularly in the case of hypertrophic cardiomyopathy or amyloid cardiomyopathy, which are associated with the development of pulmonary hypertension from unique causes, as well as rethinking how we look at different forms of valvular disease that may have been studied in classical eras quite well, but in light of changes in our understanding on hemodynamic profiles of risk, the availability of non-surgical and minimally invasive treatments for these patients, we really need to reconsider how to put pulmonary hypertension into the appropriate context for aortic, mitral, and other valvular diseases that haven't been addressed, again, recently. So let's take one example. In the case of obstructive hypertrophic cardiomyopathy, this is a disease of left ventricular hypertrophy occurring in the absence of a secondary cause that results in a dynamic left ventricular outflow tract gradient, which occurs in about 1 in 500 people. It's a common cause of left ventricular dysfunction at any age. And we now have important therapies that have been proven over decades in the case of septal reduction therapy, including myectomy, and newly advanced medical treatments, including myosin inhibitors, as well as in cardiac amyloidosis, which is most commonly due to transthyretin protein disruption and causes severe impairment to LV lusitropy, but for which there are transthyretin protein stabilizer treatments that are used increasingly. And we look forward to second and third generation versions of these drugs, which we anticipate will have even stronger clinical impact than what we've seen thus far. So thinking a little bit about the use case of hypertrophic cardiomyopathy, these are data from a sizable cohort of patients referred for septal reduction treatment at a specialized center in whom right heart catheterization is done as part of the standard clinical care approach. And as you can see in this cohort, almost 3/4 of patients have an elevated mean pulmonary artery pressure, meeting the sine qua non clinical criterion or hemodynamic criterion for pulmonary hypertension. And that this corresponds to an interesting histopathophenolitic pattern that was observed and studied in a second historical cohort of patients referred to the clinical center at the National Institutes of Health, and for whom a mortality event was determined from a separate cause, but autopsy was able to capture information on pulmonary vascular remodeling in a small group that had also undergone right heart catheterization. And you can see here that even mildly elevated pulmonary artery pressure levels in the case where I report here a median of 25 millimeters of mercury, that there is a substantial fibroproliferative and hypertrophic remodeling pattern in these pulmonary arterioles, leading us to observe a pathologic correlate to mildly elevated pulmonary pressure in this disease, indicating an extracardiac target of end organ injury, reinforcing the importance of pulmonary hypertension as a part of this syndrome of HCM. And we also know that patients will go on to demonstrate other hemodynamic features of PH. Over a third of the patients had an elevated pulmonary vascular resistance using the classical cutoff of 3 Wood units. And even among them, despite a left heart disease cause at the time of right heart catheterization, resting in supine, 11% of these patients had a precapillary phenotype. Now, how that changes with exercise or with moving in this disease is not known, but suffice to say that PH is common, pulmonary vascular disease is common in this disease, and we have to keep this in mind when thinking a little bit about risk stratification for myectomy and other potential treatments. And so more information is needed prospectively to put this into direct focus. But overall, I think it provides a clear rationale that specific subgroups of left heart disease deserve particular consideration when thinking about how PH should be assessed, managed, and then studied moving forward. So in the case of HCM, further data are needed to clarify the clinical relevance of PH in post-myectomy patients that may experience residual heart failure, which is uncommon. But PH itself may give us a clue into understanding that important subgroup. The role of PH in stratifying patient candidacy for myosin inhibitor has not been examined, but is something that probably needs to be evaluated systematically as well. And then, of course, in the case of cardiac amyloidosis, understanding how PH affects medical treatment response or can be used to clarify clinical decision-making in affected patients is quite welcome. Now, similar information needs to be considered in the case of overlapping phenotypes as well as in patients with primary valve disease. Here you can see information collected from the PVD Omics prospective clinical cross-sectional research study in the US that identifies substantial overlap between multiple World Symposium PH clinical groups. There's almost 40% of patients that overlap in two groups. And this is even when the advantage of well-phenotyped clinical information that's collected in a standardized way and reviewed by a cohort of clinical experts gets a chance to weigh in on optimal primary diagnosis. It's very clear that in real practice, we just simply have a lot of overlap. And this issue needs to be, I think, studied more specifically when it comes to group 2 PH, since that is, of course, the most common subgroup of PH worldwide. So what are our ways in which we can use diagnostic maneuvers or other assessment tools to tweak out the probability that left heart disease is in play? We refer back to the prior World Symposium PH consensus document by Vascieri and colleagues implicating an intermediate and high risk differentiation based on pretest probability of PH HFpEF that's driven by imaging information, electrocardiography, even risk factors, and ultimately is used to inform the likelihood that a patient presenting to you with a particular PH syndrome harbors a HFpEF driver of that syndrome. And then, of course, specific invasive provocative maneuvers that include right heart catheterization and the possibility of confrontational fluid challenge or other maneuvers such as invasive cardiopulmonary exercise testing with exercise is an important consideration to unmask heart failure with preserved ejection fraction that may appear to be out of play at rest and supine, but becomes more clear as part of a patient's exercise limitation syndrome once those maneuvers are elucidated. So we support this approach and expand the idea of these provocative challenges in patients, even with borderline pulmonary artery wedge pressures or those with intermediate high probability of PH left heart disease. And we also add into the fold the importance of validated pretest probability scores, including H2, HFpEF, and the HFA-PEF scores, which allow common comorbidities in aggregate to inform on the likelihood that a patient who has PH is presenting at least with a contribution of left heart disease fundamentally. Earlier right heart catheterization is also proposed for diagnosis so that patients are appropriately classified as left heart disease in the setting of an elevated wedge, as opposed to following complete diuresis, which may give a false impression of isolated precapillary PH. And then provocative testing, as I mentioned earlier, is appropriate for borderline wedge pressure patients. And even there is some data suggesting that those who have risk factors and a wedge pressure of less than 13 millimeters of mercury may nonetheless demonstrate a left heart disease phenotype once complete diagnostic testing is finalized. Another important consideration when thinking about overlapping phenotypes is just the frank common overlap between lung disease and left heart disease. These are data from Eckert and colleagues published in the European Heart Journal that show a substantial number of incident heart failure cases in a predominant lung phenotyped subgroup, in which lung function impairment, either in the case of restrictive physiology or obstructive physiology, is nonetheless observed frequently in patients who have left ventricular hypertrophy or adverse cardiac remodeling. And overall, these two problems, left heart disease and lung disease, have been described as comorbidities in many different epidemiologic and cross-sectional reports, and oftentimes are associated with an increase in mortality risk. So we really have a responsibility to optimize our clinical phenotyping of patients, even in regular clinical care. As a cardiologist, I recognize it's particularly important to understand potential underlying lung disease. Often will partner with a pulmonologist to ensure that I am not missing an important cause of dyspnea that I'm misattributing to a cardiac cause, and vice versa. I will oftentimes receive helpful consultations from pulmonologists and aim to identify a cardiac or left heart disease cause of a symptom profile. And this principle can be expanded into more specific and nuanced presentations, including in the case of chronic thromboembolic pulmonary hypertension, where left ventricular dysfunction is surprisingly common, and when present is associated with an increase in adverse outcome, at least as determined hemodynamically in patients with a left ventricular end-diastolic pressure of greater than 15 millimeters of mercury. And I think this reflects an aging population that's diagnosed with CTEPH, and the possibility that substantial changes in right heart physiology can influence left ventricular filling pressure and overall create a biventricular cardiac dysfunction pattern that has only been recognized recently. So key gaps in evidence for this theme include more information that is needed on exercise protocols for invasive hemodynamics, particularly around the concept of standardization, since even today, many different laboratories perform tests using different approaches. For patients with left heart disease risk factors and a positive fluid challenge, data on outcomes with and without PH therapy were identified as an important unmet need. And then treatment strategies for overlapping group 1 and group 2 PH phenotypes are lacking, particularly with consideration to systemic sclerosis, since that particular syndrome can cause LV dysfunction as well as precapillary PH and, of course, parenchymal lung disease. So for these types of multi-organ systemic disorders, much more information is needed on how to subgroup according to organ involvement and how that plays into PH treatment response. So moving on to the fourth major theme of the task force into decentralized clinical research. This was identified as a theme based on recognizing three major problems. First, in the current randomized control trial model, access to participation in clinical trials is limited. Second, we know that there are many important clinical questions that are not feasible to be answered by a phase 3 randomized control trial. And then problem three is that there are a major unmet need to demonstrate therapeutic efficacy in real world settings after patients leave the highly confined and highly organized infrastructure of a randomized trial, which has very little translatability to real world practice. We know that the current model for clinical trial engagement involves the identification of a promising treatment that is oftentimes sponsored by a funding agency that directs site selection, a search for patients using conventional methods, including word of mouth, which oftentimes is restrictive, disruptive, and at the very least, timely and expensive. And on the other hand, decentralizing clinical research through electronic health record-based approaches that can leverage medical system data, bring in biologic or environmental information, and enroll patients at point of care through the EHR at many different hospitals at the same time, provide a community-based opportunity to address areas of equipoise, which are scalable, personalized, accessible, much cheaper, and can be rapidly implemented and changed dynamically in response to data that are collected and could inform how to optimize the clinical research framework. And the World Symposium Task Force recognized that it wasn't only their view of this, that the FDA had increasingly demonstrated focus on pragmatic clinical research as a streamlined and prospective way to fit different questions into different answers, focusing on those that are often relegated to randomization. And special promise is given when embedded in healthcare systems, avoiding prohibitive costs and loss of diverse representation. And there are already clear examples of success in addressing these areas of equipoise that have been published in high visibility journals and which have informed clinical practice. And this becomes increasingly important in our field as we recognize that the vast majority of clinical research trial data is not representative of the patients who actually harbor the diseases. We can think a little bit about that in the context of HFpEF, in which the incidence in African American or Black patients is greater than 50%, which we would anticipate to translate into representation of about 60% of trials. And yet the actual representation of patients in these studies harbors or hinders around 9%. So we see a huge gap in the expected enrollment rate of different at-risk subgroups and the actual enrollment rate of these subgroups. And the question of whether access to involvement in these trials, methods to engage more clearly is something that's modifiable was addressed and discussed by the task force. And we certainly see opportunities to transition out of the conventional model into a pragmatic clinical model to try to deconstruct some of these barriers. And you can see here on the slide, according to purpose, subtype, pros, as well as cons, some of the key advantages to pragmatic clinical studies that may be successful in accomplishing this. We also wanted to provide a preliminary example of how this type of information can be useful. In this slide, we show the geocoded distribution of patients at risk for left heart disease, PH, across the US state of Maryland that itself is color-coded by social vulnerability index at the census tract level. And each of the gray nodes in this diagram represent one of 53,000 or so individual patients at risk for pulmonary hypertension from left heart disease. And you can see that there are clear population densities that track disease densities that track with highly populated areas across the state of Maryland, one represented here in the city of Baltimore, the other outside of Washington, D.C. But what was less obvious when we began to assemble these data were density clusters that tracked more with social vulnerability patterns in rural or non-urban areas that seem to be defined in part by a greater number of patients with risk for PH than we expected. And so this raises the question of whether or not there are digital health technology opportunities to track patients outside of a centralized method, since certainly these patients in the blue circles would have a more difficult time seeking care at specialty centers if they are farther away, and social determinants of health, as well as phase 4 trials to understand post-market deployment of treatments into areas that may not necessarily be defined by readily strong access to care, as well as access to pharmacotherapies. And then finally, moving into a description and a summary of the state of the art in clinical trials, we wanted to direct attention to this work by Marius Hooper and colleagues studying the role of tadalafil for the treatment of combined post and precapillary pulmonary hypertension and heart failure, which was a phase 3 study stopped premature due to a supply chain discontinuation in the setting of COVID, but nonetheless, based on what the task force recognized as reasonably sufficient data, nonetheless showed no signal towards benefit by treatment and potential signal towards harm, including mortality in the study cohort. And so we wanted to bring back to the audience's attention that at present, there is no reproducible data to support systematically the use of pulmonary vasodilator treatments to patients with left heart disease, and that available meta-analysis data suggests the possibility of a trend in the increase of all-cause and cardiovascular mortality, as well as worsening heart failure. So it was the recommendation of the task force to reinforce the prior principle that pulmonary vasodilator therapies are not recommended for patients with left heart disease outside of a clinical trial. Take-home point of this, of course, is that those collective studies that had been presented since the 6th World Symposium, again, reinforce our position that those PAH drugs should not be used in PH left heart disease. And finally, I wanted to recognize all of the key contributors to the task force recommendations. That includes Ryan Tedford, Jean-Luc Vachiari, Irene Lang, Teresa DeMarco, Guillermo Bortman, Jessica Huston, and Stefan Rosenkrantz, who formed a very great team and tried to take consideration from the literature at hand. And I appreciate your attention here today.